Hi, my name is Barb Hunt, and I'm one of the instructors for Nursing 134, and I will be giving the narration to this PowerPoint on musculoskeletal function. So the objectives for this PowerPoint are being able to do an assessment of musculoskeletal function, and the objective is to describe the basic structure and function of the musculoskeletal function. You're going to be able to discuss the clinical indications, patient preparation, and other related nursing implications for common tests and procedures that are used to assess musculoskeletal function and musculoskeletal diseases. Management of patients with musculoskeletal disorders are part of the objectives, and you need to be able to differentiate assessment, pathophysiology, and treatment of the following disorders. We're going to be discussing acute low back pain, upper extremity disorders, and common foot problems. And then we will be also discussing some of the following disorders of osteoporosis, Paget's disease, osteomyelitis, and bone tumors. And for each of those, we're going to describe the risk factors, prevention, pathophysiology, clinical manifestations, complications, diagnostics, medical and nursing management. And then we're going to use nursing process as a framework for our care of these patients. And then there will be some medications that will be addressed, and you need to understand those as well. And for all of these conditions, you're going to be applying teaching and learning principles, and that comes out of your Taylor text to various populations. So it's very important with these patients. They'll be sent home. They need to know how to care for themselves. And so teaching these patients and using those principles are real important. So the musculoskeletal system has a variety of functions that it serves. First of all, it provides protection for vital organs, such as the brain, our heart, our liver, our kidneys, our lungs, and our spleen, because it provides a sturdy framework to support the body and to protect all of those structures. The musculoskeletal system also makes mobility possible. It's our joints and muscles and tendons and everything that work together to give our body the ability to be as flexible and all the movement that it's capable of doing, from ballet to sports. All of those things are as a result of how our musculoskeletal system works. Also, the musculoskeletal system is what allows our body to maintain body temperature. The muscles that are attached to the skeleton, they contract, they move the bones, and then by doing so they produce heat, and this helps maintain our body temperature. Also, this movement and the muscle contracture does facilitate the return of deoxygenated blood to the right side of the heart, because it massages our muscles as they contract. They massage the venous vasculature, and so it plays a role in facilitating the return of blood to the heart. In addition, the musculoskeletal system serves as a reservoir for immature blood cells. It does this because it is a place where the blood cells are produced. So the red blood cells, the white blood cells, our platelets, a lot of our immune cells are actually produced in the bone marrow, and the immature cells stay there until they mature, and then they can go out into the periphery and do what they're intended to do. So it is a place of production of our blood cells, and it's also a reservoir for those that are immature. And it also serves as a reservoir for vital minerals such as calcium, phosphorus, magnesium, and fluoride. In fact, more than 98% of the total body calcium is present in the bone. So we'll talk a little bit about the anatomy of the musculoskeletal system, the skeletal system in particular. There are two types of bone tissue. There is the cancellous and the cortical bone. The cancellous bone is trabecular, and the cortical is considered compact. The cancellous bone, or spongy bone, is found in the interior bones and forms a lattice-like pattern. Red or yellow bone marrow fills the lattice network. Cortical, or compact bone, forms the outer shell of a bone. It has a densely packed, calcified intracellular matrix, making the cortical bone more rigid than cancellous bone. There are three different types of bone cells, three basic cell types that the bone is composed of, and these are osteoblasts, which secrete bone matrix. The osteoblasts function in bone formation by secreting bone matrix. There are osteocytes. Osteocytes are mature bone cells involved in bone maintenance. And then there's the osteoclasts, and they are multinuclear cells involved in dissolving and resorbing bone. And then there's also different categories of bones. There are the long bones, such as our femur, our short bones, such as the metacarpals, the flat bones, such as our sternum, and then irregular bones, such as our vertebrae. All in all, there are 206 bones that make up our bodies and our skeletal structure. And again, these are made up of different types of bones: the long bones, the short bones, flat bones, and irregular bones. In addition to the bones, we have joints, and these are where the bones meet. And we'll talk more specifically about the different types of joints in a future slide. And then muscles as well. So the musculoskeletal structure is made up of our bones, joints, and muscles. And here in this slide are some pictures of the structure of a bone. And here's where you can see the spongy bone that contains the red marrow inside of the cell. You can see the cartilage. You can even see the growth lines. The compact bone, you see where the osteocytes are, where the blood vessels are, and then just the different anatomical points of the bone. Bone is a dynamic tissue in a constant state of turnover. During childhood, bones grow and form by a process called modeling. By early adulthood, such as in the early 20s, remodeling is the primary process that occurs. Remodeling maintains bone structure and function through simultaneous resorption, which is removal or destruction of tissue, and osteogenesis, which is bone formation. As a result, complete skeletal turnover occurs every 10 years. And this process of bone maintenance is affected by multiple factors that are chemical, hormonal, nutritional, and lifestyle in nature, and we'll talk more about those in a future slide. So as mentioned in the previous slide, the bone is in a constant state of turnover, and there are a variety of regulating factors that play a role in the formation and maintenance of bone health. Physical activity, particularly weight-bearing activity, is very important for bone health. Weight-bearing activity stimulates bone formation and remodeling. Bones that are subjected to continued weight-bearing tend to be thick and strong. So people who aren't able to engage in regular weight-bearing activities, such as those on prolonged bed rest or those who have disabilities, they have an increased bone resorption from calcium loss, and their bones tend to become brittle, osteopenic, and weak, and therefore they're at risk for fractures. Diet plays a big role in bone health as well. In particular, the absorption of calcium is important to bone health. Adults need approximately 1,200 milligrams of calcium daily to maintain bone health, and for postmenopausal women, that goes up to 1,500 milligrams. It's essential in order to maintain bone health and prevent bone loss. This can be achieved by eating foods that are rich in calcium on a daily basis, And some of those foods that are good sources of calcium include dairy products such as milk, yogurt, and cheeses. Some of our green leafy vegetables are good sources of calcium. Cooked collard greens, Chinese cabbage, kale, broccoli, even rhubarb is a good source. Some of our seafood, such as sardines, oysters, clams, and canned salmon with bones are a good source of calcium. Tofu has calcium in it. And then, of course, we can get calcium from calcium-fortified fruit juices, fruit drinks, and even cereals. Now, several hormones play a vital role in ensuring bone health as well. Vitamin D, or calcitrol, is important for maintaining good bone health. Calcitrol is a biologically available vitamin D. What it does is it ensures calcium is properly absorbed from the GI tract, and therefore deficiencies in vitamin D can lead to bone mineralization deficiency, deformity, and even fracture. Another hormone is parathormone. This regulates the amount of calcium in the blood. And parathormone works together in conjunction with calcitonin to regulate calcium homeostasis. So parathormone promotes movement of calcium from the bone into the bloodstream. And for calcitonin, it's secreted by the thyroid when the calcium levels in the blood are high. And then it goes ahead and inhibits the breakdown of bone and increases the calcium in the bone. So the parathormone, what it does is when calcium, it increases the calcium levels in the blood. And then the calcitonin, if the calcium levels are high in the blood, what it does is it will take it out of the bloodstream and increase calcium to the bone. So they work in conjunction for that homeostasis. Thyroid hormone also is another hormone that plays a role in bone health. And what it does is it can result in increased bone resorption and decreased bone formation. So someone with high levels of thyroid, such those with Graves' disease, they can have issues with decreased bone mass and bone formation. Cortisol, another hormone in our body, kind of that fight response and stress hormone, it has similar effects. So patients who are on corticosteroids, some sort of steroids like prednisone, they end up having increased risk for steroid-induced osteopenia and fractures because their bone then becomes very brittle and weak when they're on long-term steroids, because cortisol has a similar effect. Growth hormone also can have effect on bone health, and it plays a big role in children and adolescents in the formation of bone. It accelerates bone modeling in children and it stimulates skeletal growth in children and adolescents. Estrogen plays a role as well. It enhances bone formation. And so with women who are postmenopausal, who have low levels of estrogen, it can lead to decreased bone density. Testosterone, the male hormone, also plays a role in bone formation and growth. It promotes skeletal growth and increased bone formation in adolescents and in children. And the blood supply is very, very important to bone health. With a decreased blood supply, it can lead to decreased bone density and even bone necrosis. So there's a process for bone healing that takes place, which starts with the body responding to a fracture by bleeding into that injured tissue and forming a fracture hematoma. Inflammatory cells then migrate into that injured area, and they release growth factors that then stimulate the osteoclasts and osteoblasts to be active. Inflammation, swelling, and pain are all present, and this inflammatory stage lasts several days and resolves with a decrease in pain and swelling. The next phase then is angiogenesis. There's new capillaries that then infiltrate the hematoma, and fibroblasts then enter into that area, and it makes a bridge of tissue that's called a callus. It's a soft tissue callus that then establishes a connection between the bone fragments. After that, the cartilage then becomes calcified. Enzymes within the matrix vesicles prepare the cartilage for calcium release and deposit. And then the next step is the cartilage removal. This is where the cartilage is able to be removed, but it's replaced by woven bone similar to that of the growth plate. And then the bone formation takes place, and this is where minerals then are deposited until the bone is firmly reunited. With major adult long bone fractures, this process of ossification, or the making of a bone, takes approximately 3 to 4 months. And then the final stage is that of remodeling. This is the final stage of fracture repair, and it ends up creating that new bone to become very similar to the formal structural arrangement of the previous bone before injury. And remodeling may take months or even up to years, depending on the extent of bone modification that's needed, the function of the bone, and the stresses that are on the bone. So how do we monitor the progress of bone healing? Well, we use serial x-rays. So periodically x-rays will be done to monitor the stages and the completion of bone healing. And it's very, very important for the bone to be immobilized. It's essential until there's x-ray evidence of bone formation with ossification in order for that bone to heal. So here we have a question to just to review a little bit some of the things that we've been learning. So here's your question. An adequate dietary intake of vitamin D is necessary to A, suppress the activity of osteoclasts, B, maintain metabolic activity at the epiphysis, C, promote calcium absorption from the GI tract, or D, prevent uncontrolled bone remodeling. The correct answer is C. Vitamin D promotes calcium absorption from the GI tract. So there's 3 different types of joints, categories of joints. There's synarthrosis joints. These are immovable joints. An example of that would be the skull suture joints in our skull. Then there's the amphithrosis joint. This does allow for limited movement. An example of that would be our vertebral joint in our spine. And then the diarthrosis joints. These are freely movable joints, and there's 5 different categories of these: the ball and socket, hinge, saddle, pivot, and gliding joints. And we'll talk about those in future slides. So the ball and socket joints, they permit full freedom of movement. So a good example of that would be the hip joint and the shoulder joint. The hinge joint, these permit bending in one direction only, and examples of that would be the elbow or the knee. Saddle joints allow movement in 2 places at right angles to each other. The joint at the base of the thumb is the saddle joint. Pivot joints are characterized by articulation between the radius and the ulna. They permit rotation for such activities as turning a doorknob. And then gliding joints allow for limited movement in all directions and are represented by the joints in the carpal bones in the wrist. And then we have ligaments. These are fibrous connective tissue bands. They bind the articulating bones together. So ligaments and muscle tendons, which pass over the joint, provide joint stability. And the bursa, this is a sac filled with synovial fluid that cushions the movement of tendons, ligaments, and bones at a point of friction. And the bursa are found in the elbow, the shoulder, the knee, and some other joints. So we have another question. The knuckles of the fingers would be an example of what kind of a joint? Ball and socket, hinge, saddle, or pivot? What do you think? It's an example of a hinge. Hinge joints, such as the knuckles, are characterized by the fact that they permit bending in one direction only. And then some other items in our musculoskeletal system are the tendons. These attach muscles to bones, connective tissue, other muscles, soft tissue, or even skin. The fascia, this is a fibrous tissue that encases muscles. And then the skeletal or striated muscles, they're involved in body movement, posture, and heat production functions, as I mentioned earlier. So there are different descriptors for muscles and what can happen to them. Relaxed muscles demonstrate a state of readiness to respond to contraction stimuli. So this state of readiness is known as muscle tone or tonus. A muscle that is limp and without tone is described as flaccid. A muscle with greater than normal tone is described as spastic. And in conditions that are characterized by lower motor neuron destruction, such as polio, denervated muscle becomes atonic, soft and flabby, and atrophies. And paralysis, it's a loss of movement and possibly from nerve damage. And it is possible to be able to retrain functioning muscles within that synergistic group of muscles to produce needed movement even if somebody does develop paralysis. Enlargement of a muscle is called hypertrophy. Muscles do get larger with use, so with exercise and with use. When a muscle is repeatedly exercised, it can develop maximum or close to maximum tension over a long time. It becomes enlarged or it hypertrophies. The opposite phenomenon occurs with the disuse of the muscle. If you don't use it, you lose it. And over a long period of time, age and disuse can cause loss of muscular function, and this can decrease the size of a muscle, and that's called atrophy. So it's real important with your patients to let them know that they need to keep using their muscles, because if they don't use it, they are going to lose it. It will atrophy, and it's hard to regain that then afterwards. So in summary, muscles are attached to bones and other structures by tendons. They're encased by a fibrous tissue sheath called a fascia. Contraction of the muscle is what is the cause of our movement. And muscle cell fibers react to electrical stimulation, so they need to be stimulated in order to contract and to allow movement. And with strenuous muscle activity, the utilization of anaerobic pathways are used, and that frees up glucose that's metabolized from stored glycogen in order to provide the energy needed for sustained muscle activity. So nursing assessment with the patient with a musculoskeletal dysfunction, the patient will usually present with some sort of complaint of pain or tenderness. Bone pain is characteristically described as dull, deep ache that is boring or penetrating in nature. Muscular pain, however, is described as a soreness or aching, or could be referred to as a muscle cramp. And somebody with a fracture, their fracture pain usually is described as sharp and piercing, and it's usually relieved by immobilization. Then the other complaints that you'll see with patients with musculoskeletal issues are altered sensations, and we'll talk about that in the next slide. When assessing for altered sensation, I like to think in terms of CMS checks, C standing for circulatory, M for motion or movement, and N for sensation. And again, you're going to want to compare the affected extremity with the non-affected extremity. So you want to compare to see if there's any differences. So in circulatory, you're going to look for several things. You're going to look for 4 things in particular: the color, the temperature, capillary refill, which should be less than 3 seconds, and the presence of pulses and the strength of the pulses distal to the injury. Movement, are they able to move and have normal movement or motion? And then any issues with sensation. Do they have any abnormal sensations, tingling, numbness? You can check them for tactile sensation. Can they feel when you touch them? Are they having pain? And then for any of these abnormal sensations, how long has it lasted or persisted? Is it getting worse? What makes it better? What makes it worse? Those kinds of questions. Some other assessments you want to look for is there any edema? And if there is edema present, is it pitting edema and to what degree? And then is there anything restricting the circulation or putting pressure on the nerves that might be causing some of the issues? Another way to look at this too is for the 5 Ps when you're assessing altered sensation. You're assessing for pain, pallor, which speaks to the color, pulses, paresthesia, and paralysis. So those are kind of the 5 Ps you can think of in terms of musculoskeletal assessment. So some of the indicators of peripheral neurovascular dysfunction would be in the area of circulation if the color were pale, cyanotic, or mottled, and the temperature if it's cool, and the capillary refill if it's more than 2 seconds. For motion, if they're having weakness or paralysis, and the sensations, if they're having paresthesia, unrelenting pain, pain on passive stretch, and absence of feeling. So those are some of the indicators of peripheral neurovascular dysfunction, which would then, be of great concern. And there's something that needs to be addressed with that patient because they're having a problem. Further nursing assessment for the patient with musculoskeletal dysfunction involves inspection and palpation addressing the following. You're going to look at their posture, and we'll kind of talk in the future slides about some of the variations in posture that you might see. You can have them walk and see how is their gait. Is it steady? Is it uneven? You can do an assessment and inspection of bone integrity. Do they have any issues with the bone or a break through the skin? How is the joint function? Is it able to do the mobility that it's intended to do for that particular joint? What's the tone of the muscle? What's the muscle strength? What's the muscle size? Are they having any atrophy or any enlargement? Any issues with that? Skin, is it intact? Is there a breakdown? And then the neurovascular status, which is basically what we kind of addressed in the previous slide. So when assessing the musculoskeletal system, include data related to function of their ability. Are they able to do activities of daily living independently or not? Their ability to perform various activities, and especially related to mobility. And then gather their health history, their family history, their general health maintenance. Are they having good lifestyle choices? How is their nutrition, their activity, their exercise? Also, occupation is an important thing to talk to them about, and their activity level, because that does speak to musculoskeletal strain. Some occupations have a higher risk for musculoskeletal injury, or even some high levels of activity. Runners, those kinds of things, can also have high levels of musculoskeletal injury. And then, of course, you're going to be assessing what their learning needs are, their learning preferences, understanding the socioeconomic factors, and then are they taking any medications? As we mentioned previously, some medications can lead to decreased bone mass and complications. So also include the over-the-counter medications, any supplements that they might be having. And then doing a good assessment of their pain and the altered sensations as we talked about, and assessing all these other things as we mentioned in the previous slide. So this slide is showing the normal spine and 3 abnormalities. In A, this is a kyphosis, and what this is, it's an increased convexity or roundness of the spine's thoracic curve. In B, this is lordosis. This is a sway back or an exaggeration of the lumbar spine curve. And C is scoliosis. It's a lateral curvature of the spine. You can almost see that the spine almost looks like an S. Kyphosis is frequently seen in elderly patients with osteoporosis and in some patients with neuromuscular diseases. Scoliosis may be congenital or even idiopathic, where we don't even know what the identifiable cause is, or it could be the result of damage to the paraspinal muscles, as in polio. And lordosis, it's frequently seen during pregnancy as a woman adjusts her posture in response to changes in her center of gravity. Well, here's another question for you. Is the following statement true or false? When assessing the gait of an older adult, the nurse should consider unsteadiness and irregularity of movement to be normal assessment findings. True or false? That's false. Even though gait disturbances are more common in older adults, unsteadiness and irregularity are still considered to be abnormal assessment findings. There are a variety of diagnostic tests that are used to perform when there's musculoskeletal dysfunction or injury. X-ray studies are really the primary mode for determining fracture and musculoskeletal disorders. Bone X-rays determine bone density, texture, erosion, and changes in bone relationships. So they're very frequently used. Computer tomography, or CT, this can show a little bit more detail for a specific injury that may not be seen in X-ray. It can reveal tumors of the soft tissue or injuries in the ligaments and tendons. So it can see things that the X-rays won't be able to demonstrate. MRI, or magnetic resonance imaging, this is a non-invasive imaging technique. It does use magnetic fields, radio waves, and computers, and it can demonstrate abnormalities of soft tissues such as muscle, tendon, cartilage, nerve, and fat. Because it is an electromagnet, though, patients with any metal implants, clips, or pacemakers are not candidates for MRIs. In fact, jewelry, hair clips, hearing aids, credit cards with magnetic strips, and other metal-containing objects must be removed before the MRI is performed. Otherwise, they can become dangerous projectile objects or cause burns. Credit cards with magnetic strips may be erased, and non-removable cochlear devices can become inoperable. Also, transdermal patches such as Nicoderm or Catapress or scopolamine, they often have a thin layer of aluminum backing, so they must be removed before an MRI is done because they can actually cause burns. Another diagnostic test would be an arthrography. This is useful in identifying acute or chronic tears of a joint capsule or supporting ligaments of the knee, shoulder, ankle, hip, or wrist. A radiopeg contrast agent or air is injected into the joint cavity to outline the soft tissue structures and the contour of the joint. And then the joint is put through its normal range of motion to distribute the contrast agent while a series of X-rays are taken. If the tear is present, then the contrast agent will leak out into the joint and out of the joint, and that would be evident on X-ray image. After an arthrogram, a compression elastic bandage is applied as prescribed, and the joint is usually rested for about 12 hours. Another test would be the bone densitometry. This is used to estimate bone mineral density. It can be performed through the use of X-rays or even ultrasound. And a DEXA scan, which is a dual energy X-ray absorptiometry scan. This determines bone mineral density at the wrist, hip, or spine, and it can estimate the extent of osteoporosis and help monitor a patient's response to treatment for osteoporosis. Bone scan, this can be performed to detect metastatic and primary bone tumors. It can also detect osteomyelitis, certain fractures, and aseptic necrosis. For this, a bone-seeking radioisotope is injected intravenously, and then the scan is performed a couple of hours after the injection. At this point, the distribution and concentration of the radioisotope in the bone are measured, and the degree of the nuclide uptake is related to the metabolism of the bone. So an increased uptake of radioisotope is seen in primary skeletal disease, such as osteosarcoma, metastatic bone disease, inflammatory skeletal disease, such as osteomyelitis, and certain types of fractures. So if any contrast agent is used, such as in the bone scan or for a CAT scan or even for an MRI, it's important for the nurse to be sure to assess for any allergy that the patient might have. And then also after the patient has the test, we want to make sure that they drink plenty of fluids and have increased fluids in order to be able to clear out that contrast or dye from their system. Another diagnostic evaluation test is arthroscopy. This is a procedure that allows direct visualization of a joint to diagnose joint disorders. Treatment of tears, defects, and disease processes may be performed through an arthroscope as well. The procedure is performed in the operating room under sterile conditions, and an injection of a local anesthetic into the joint or general anesthesia is used. After the procedure is done, the joint is wrapped with a compression dressing to help control swelling. In addition, ice may be applied to control edema or discomfort afterwards. So an arthrocentesis, this is a joint aspiration. It's carried out to obtain synovial fluid for purposes of examination or to relieve pain due to effusion. It can help diagnose septic arthritis and other inflammatory conditions. And what happens is synovial fluid is withdrawn or aspirated, and it's usually, in appearance, should be clear, pale, straw-colored, or scanty in volume. Using aseptic technique, the physician inserts a needle into the joint and aspirates the fluid. Sometimes anti-inflammatory medication may also be injected into the joint. A sterile dressing then is applied after aspiration, and as in any invasive procedure, there is a risk of infection after this procedure. Electromyography, or EMG, this provides information about the electrical potential of the muscles and the nerves leading to them. It's performed to evaluate muscle weakness, pain, and disability, and its purpose is to determine any abnormality of function and to differentiate muscle and nerve problems. Needle electrodes are inserted into selected muscles, and responses to electrical stimuli are recorded on an oscilloscope. And biopsy is another diagnostic evaluation. It may be performed to determine the structure and composition of bone marrow, the bone itself, muscle, or synovium, and it can help diagnose specific diseases. So as a nurse, you're going to prepare the patient by providing teaching about the procedure, obtaining consent, giving any pain medications that's needed. Sometimes this is done under conscious sedation. And then after the procedure, you're going to monitor the biopsy site for any bleeding, swelling, sign of infection, and sometimes ice is applied, and sometimes pain medications may be needed as well. And then finally, laboratory studies may be conducted as well. The CBC can give us information about the hemoglobin, if there's any bleeding and decrease in hemoglobin due to maybe a large bone fracture, or white blood count, is there an infection or osteomyelitis going on. Coagulation studies may be done before surgery is done to detect any bleeding tendencies or problems. The blood chemistry can provide information about electrolytes such as calcium levels, phosphorus levels. Serum phosphorus levels are inversely related to calcium levels, so we usually look at those together. Acid phosphatase is something that is elevated in Paget's disease and metastatic cancer. We might also want to look at calcitonin levels, parathormone levels, vitamin D levels, calcium levels, even calcium levels in the urine. So anyway, there's a lot of variety of laboratory studies that might be involved as well. So another question for you. Which statement is false about magnetic resonance imaging? Credit cards with magnetic strips may be erased. Non-removable cochlear implant devices can become inoperable. Transdermal patches that have a thin layer of aluminized back must be covered with gauze. Jewelry and hair clips must be removed before the MRI is performed. The answer is C. Transdermal patches that have a thin layer of aluminized back must be removed because they could cause burns. Okay, now we're going to get into the section where we get into some very specific musculoskeletal disorders. But before we get into the specific musculoskeletal disorders, I would like to just have an overview of some of the common musculoskeletal nursing diagnoses because they pretty much apply to all of them. And as mentioned previously, that one of the symptoms that people have with musculoskeletal disorders is they have pain. So acute and chronic pain is very oftentimes nursing diagnosis used. And then this can affect their mobility. So impaired physical mobility is another very common one. And then we had talked about peripheral tissue perfusion or neurovascular dysfunction. And so risk for ineffective peripheral tissue perfusion really is a big deal. That's an important nursing diagnosis. It many times can be a priority nursing diagnosis because if they aren't getting perfused, then tissue is going to die and there'll be damage that could be irreversible. So that's a very important one as well. Risk for infection for any time that there's an opening in the skin or an invasive procedure. Risk for impaired skin integrity. Many times these patients are immobile, and so just by definition they're pretty much at risk for breakdown in their skin because of their lack of mobility. Their ability to care for themselves is affected oftentimes, so self-care deficit is an important one. Knowledge deficit, as mentioned previously, patient education is huge. They're going to have to learn how to take care of themselves, to follow any precautions, to know what things to report. Risk for injury, there may be weakness, instability, they may be learning new gaits with a walker or with crutches, so risk for injury is a big one as well. And then risk for situational low self-esteem due to some of the changes maybe in their lifestyle, their mobility, and their ability. So that's another common nursing diagnosis. And then some of the outcomes and goals, which of course would be related with the specific nursing diagnosis. So if they have acute or chronic pain, you want relief of pain. Impaired mobility, you want improved mobility, at least to maintain their mobility and hopefully improve it. We want to ensure adequate tissue perfusion. Any absence, and we want to also ensure absence of complications. We want them to be able to let us know and demonstrate knowledge of therapeutic regimen, and then we want to for sure prevent injury. And for interventions, patient teaching is necessary for their understanding. Neurovascular assessment is vital. After a major surgery or injury, every hour for the first 24 hours is necessary. And then you instruct the patient in signs and symptoms to assess, to report. We can do the 5 Ps or the CMS checks, and then report immediately any neurovascular dysfunction that there is, because that needs to be reported right away. We need to manage their pain. We need to prevent infection and then observe for any and pick up on any signs of infection so it can be treated promptly. And then assistance with ADLs and measures to promote independence. So there's a variety of potential complications that can occur with musculoskeletal problems. Bleeding. If somebody has a fracture, especially a pelvic fracture or enlarged bone, there may be internal bleeding that you don't even know about, and you'll have to pick up on with vital signs, hemoglobin, signs of hypovolemic shock, those kinds of things you're going to watch for bleeding. And of course, if there is a break in the skin, You're going to be observing for any bleeding, or after any surgery procedure, you're going to assess the surgery site for signs of bleeding as well. Compartment syndrome is a possible complication in musculoskeletal, and what it is this is when pressure increases, or increased pressure builds up in an enclosed space in the body, and it can lead to muscle and nerve damage or necrosis. So people who have casts on, this can be a problem. For people who have injury or swelling or bleeding or injury and swelling, it can also cause compartment syndrome as well. So if there's injury to the leg or swelling or bleeding in the leg, it can lead to that as well. So that needs to be picked up on and treated promptly, and we'll talk more about that later. Fat embolism, this is caused by fractured long bones or soft tissue trauma, and it oftentimes can happen 24 to 72 hours after the initial injury. And what you're going to see is hypoxemia, respiratory insufficiency, even to the point where the patient might need to be put on a ventilator. So what kind of symptoms might you see? Well, your patient might get restless, short of breath, have difficulty breathing. When you assess their lung sounds, you might hear wheezes. When you look at their pulse ox, it may be going down and inadequate. And so if you have a patient who has had a fracture of the long bone or some sort of soft tissue trauma, you would suspect fat embolism as the culprit for those symptoms. As mentioned previously, patients are at risk for neurovascular compromise, and we already talked about how to assess for that. Avascular necrosis, this is the death of bone tissue due to lack of blood supply, so that could happen. Malunion or non-union of fracture ends, if they aren't lined up properly, they may join improperly or not join at all. Disuse syndrome, this is the deterioration of body systems due to musculoskeletal inactivity, and what you'll see is muscle weakness, decreased range of motion. There can be even respiratory function compromise. So again, if you don't use it, you're going to lose it. So this can happen in musculoskeletal conditions. And then other risk of complications due to immobility, DVT, pneumonia, due to skin breakdown, infection, and then there's edema that could possibly occur as well. So the first musculoskeletal condition that we're going to talk about, or disorder, is acute low back pain. Low back pain is one of the most common reasons for a visit to a provider, and it's primarily caused by one of many musculoskeletal problems, including acute lumbosacral strain, unstable lumbosacral ligaments and weak muscles, osteoarthritis of the spine, spinal stenosis, intervertebral disc problems, and unequal leg length. Older adults may experience back pain associated with osteoporosis or vertebral fractures or bone metastasis. And other causes include kidney disorders, pelvic problems, retroperitoneal tumors, abdominal aortic aneurysms. So in addition, obesity, stress, and occasionally depression may contribute to low back pain. I know I had a patient when I was taking care of some psych patients, and his presenting symptom was low back pain, and it was actually a result of depression. Back pain due to musculoskeletal disorders usually is aggravated by activity, whereas pain due to other conditions is not. So acute low back pain is caused by a wide variety of problems. It may result in involvement by muscles or discs. The pain and patterns of location may vary depending on the condition. And management then focuses on relief of pain, activity modification, using back conserving techniques of body mechanics, improved self-esteem, and weight reduction. So when doing an assessment, a nursing assessment for a patient with low back pain, you want to get a detailed description of the pain and do that complete pain assessment. The location of the pain, the severity, the duration, the characteristics, how do they describe it, does it radiate, or radiculopathy, that's what that refers to. Any other associated symptoms? Are they experiencing like weakness? How did the pain occur? What aggravates it? What alleviates it? And how has the patient been managing it, and has it been helping? An important assessment for musculoskeletal, and especially related to low back pain, is what kind of work do they do? What kind of recreational activities? There's a lot of work-related injuries, a lot of vocations that are high risk for back pain. Healthcare professions is one of them. So, what is their occupation? And what are they doing recreationally? Because that can lead to some of the problems and injury that they're experiencing. And then, are they able to do activities of daily living? What are their limitations as a result of the injury? And then do an assessment, inspection of their posture, position changes, their ability to walk, how is their gait. And then a physical exam. You're going to look at the spinal curvature, the symmetry of their back and their legs, their ability to move, deep tendon reflexes, sensation, their muscle strength. And if they're obese, they'll need a complete nutritional assessment as well. So some of the nursing diagnoses, as mentioned before, but specific to low back pain, of course, acute pain, impaired physical mobility, risk for situational low self-esteem, and imbalanced nutrition. And, we want to relieve the pain as a goal. We want to improve their mobility and help them learn those back conservation techniques and proper body mechanics, and hopefully help them with the rate reduction. So they'll be on pain management, and maybe a combination of medication, including nonsteroidal anti-inflammatories, and maybe even some narcotics. Exercise to strengthen the muscles that support the back. Reinforcement or teaching of good body mechanics to hopefully prevent increasing the injury and future injuries. Work modifications, stress reduction, and then health promotion, activities that promote a healthy back. And then dietary planning and getting them on a weight reduction program, which can really help prevent the stress on the back. So here's a picture about positioning to promote lumbar flexion. This will help decrease pain in the back and pressure on the lower back. And you see the patient here lying laterally with the knees and hip flexed, with a pillow between the knees and then a pillow under the head. Another position that is helpful as well is elevating the head of the bed approximately 30 degrees with the knees flexed. So you can have the knees up a little bit, maybe a pillow under the knees, and that takes pressure off the lower portion of the back as well. But it would be important to avoid the prone position because that puts pressure on the back, and we want to avoid that. So here's a question for you. In an effort to manage a patient's lower back pain, the nurse should recommend which of the following measures? Bed rest whenever possible, activity reduction, weight loss, avoidance of over-the-counter analgesics. The answer is C, weight loss. Obesity is a major risk factor for lower back pain. So as far as posture has implications for back health and wellness as well. So poor posture can lead to increased risks of back pain. So proper and improper standing postures are here in this picture, and it's important to have really good posture in order to support the back and prevent injury. And proper and improper lifting techniques. You want to get close to the object. Do not bend over when lifting the object. Lift with your legs, and avoid twisting and turning while you're lifting objects as well. So is the following statement true or false? Proper standing posture occurs when the abdominal muscles contract, giving a feeling of upward pull, and the gluteal muscles contract, giving a downward pull. And that's true. Okay, well, we have a back pain case study. We have a patient. Her name is Jane Wagner. She's 22 years old with no previous medical history. and she presents to the emergency department with a complaint of low back pain after slipping on a wet floor at work and falling. The patient states that the pain is constant aching, radiates down both legs, sciatica, and the MRI shows pulled muscles and ligaments surrounding the L4, L5 area. The emergency physician provides the following discharge orders: bed rest with bathroom privileges for 2 days, apply ice pack to lower back for 20 minutes several times a day for the first 48 hours, and then starting day 3 and on, apply a heating pad for 20 minutes on and 20 minutes off several times per day for the next several days as needed to relieve pain. Take 400 milligrams of ibuprofen every 6 hours and 5 milligrams of cyclobenzaprine or Flexeril 3 times a day after 2 days of bed rest. Sit in chair 3 times per day and no more than 20 minutes. Ambulate around home and yard as tolerated, gradually increasing activity. Avoid twisting, bending, or reaching for objects. Avoid lifting anything more than 5 pounds of weight for 1 week. See physician in 1 week for further evaluation. So explain the rationale for the administration of ice for 48 hours, followed by the application of heat. Well, for the first 48 hours, this is the inflammatory phase of injury, and the ice can help decrease the inflammation. But after 48 hours, heat can be used to increase circulation, to promote healing, and to increase blood flow to the area, which would promote the healing. Explain the rationale for the administration of ibuprofen and muscle relaxer. Well, the ibuprofen is a non-steroidal anti-inflammatory, so it can decrease the inflammation, which then in turn can decrease pain. And the muscle relaxer can help relax a tense muscle. So what are the expected patient outcomes for the patient in this case study? Well, we want the patient's pain to resolve, and we would like the activity level to increase and return to normal, and we'd like her to be able to return to work. Now we're going to talk about some of the upper extremity problems. Bursitis and tendinitis. These are inflammatory conditions that commonly occur in the shoulder. Impingement syndrome, supraspinatus and bicep tendons become irritated and edematous and press against the acromion process, limiting shoulder motion. Carpal tunnel syndrome occurs when the median nerve at the wrist is compressed. A ganglion, this is a collection of gelatinous material near the tendon sheaths and joints that appears as a round, firm, compressible cystic swelling. And Dupuytren's disease, this results in a slowly progressive contracture of the palmar fascia, and we'll get into each of these individually. So bursitis and tendinitis, it's inflammation. Bursitis is inflammation of fluid-filled sac cushion between the bone and tendon, and oftentimes happens in the shoulder or even in the elbow. It's very painful when it's inflamed. Tendinitis, it's inflammation of a muscle tendon sheath, and this is from repetitive use and treatment and stretching. And conservative treatment for these is rest, putting on ice and intermittently with heat, and the use of non-steroidal anti-inflammatories. Impingement syndrome, this is from overuse. It's a clinical syndrome which occurs when the tendons of the rotator cuff muscles become irritated and inflamed, and this can result in pain, weakness, and loss of movement at the shoulder. Carpal tunnel is caused by repetitive movement of the hand or wrist. It also can be due to arthritis, and occurs when that median nerve at the wrist is compressed. It can lead to pain, numbness, paresthesia, and weakness. Tinel sign, this is the assessment of carpal tunnel syndrome. And what you do is you tap or percuss over the median nerve, and if it's painful, that is a positive result of the test. Ganglion. 60 to 70% of the time, it's located at the dorsum of the wrist. It's a collection of gelatinous material near the tendon sheath and joints, and it appears as a round, firm, compressible cystic swelling, usually on the dorsum of the wrist. They usually complain of it aching, and the treatment really is to watch it. Usually it will resolve, but if not, it may be the fluid might be aspirated, it may be injected with steroids, and maybe even possibly surgery done. Dupuytren's contracture. This is a flexion of the fourth and fifth fingers, may even involve the third finger as well. It's a benign thickening of the palms or fingers' connective tissue, the fascia, and it results in slowly progressive contracture of the palmar fascia. Treatment is stretching exercises to prevent it, and then if you can't prevent it, a surgery can be done, a fasciotomy can be done to correct it. The nursing care of the patient undergoing surgery of the hand or wrist. Surgery is usually done as an outpatient procedure, so you're going to be sending them home and you're going to be giving them instructions on how to care for themselves and what to report. Patient teaching is a major nursing need for these patients. You're going to need to do, before you discharge them, you're going to be doing very thorough and frequent neurovascular assessments. It's vital, the 5 Ps or the CMSs. Are they having any evidence of compromise of circulation or neurological issues? But then also let them know what things that they need to report if they're having any numbness, tingling, increase in pain, coolness of the extremity, any issues at all, so that they can report those. They'll be probably sent home on pain control measures, medication, in order to help with pain, elevating the extremity that was surgically affected is helpful, and then intermittent ice or cold, and real clear instructions on how to do that. And usually elevating them to the point of the heart or above the heart. And then preventing infection, we want to be sure to keep that dressing clean and dry, any wound care that might be needed. And then what are the signs and symptoms of infection? If they're having a fever, if they notice any redness, swelling, purulent drainage, that kind of thing. And then assistance with ADLs and measures to promote independence depending on what kind of surgery and what kind of help. They might need to have some help the first few days after surgery with ADLs. So again, having that all addressed and set up for them. So here's a question for you. What is bursitis? Is it an inflammation of a fluid-filled sac in the joint? Is it new bone growth around a sequestrum? Is it disease of a nerve root? Is it inflammation of muscle tendons? It's A. It's the inflammation of fluid-filled sac in the joint. Okay, now we're going to talk about some common foot problems. Plantar fasciitis is an inflammation of the foot supporting fascia. Hallux valgus, or bunion, is a deformity in which the great toe deviates laterally. And then Morton's neuroma, a swelling of the third lateral branch of the median plantar nerve. So plantar fasciitis is inflammation of the foot supporting fascia, and you can see in the picture the location of where that occurs. Symptoms includes heel pain, usually with the first steps in the morning, so it's really painful getting up and starting to walk in the morning. So stretching exercises can help. Wearing shoes that have support and cushioning to relieve the pain, so maybe some orthotic inserts. And then steroid injections, so a cortisone injection might be necessary as well. The hallux valgus, or bunion, it's a deformity in which the great toe deviates laterally, and that can be corrected surgically. As well as Morton's neuroma, it's a swelling of the third lateral branch of the median plantar nerve, and you see in the picture here where that's located. And again, if it's not able to be treated conservatively, surgery then can remove that and help with that. So surgery of the foot is usually, again, just like in the hand, it's an outpatient procedure. So again, outpatient preoperative assessment, patient knowledge, letting them know about the procedure, what to expect, getting consent, and then afterwards how to care for themselves. Neurovascular assessment of the foot, making sure that there's good circulation, not any problems, and then assessing their ambulation and balance. And home assistance might be necessary because it's going to be difficult for them to get around, and addressing all of those issues as far as self-care and ability to care for themselves in their home or have somebody help them. So the diagnoses, I've kind of gone through these before, but peripheral tissue perfusion, risk for ineffective. Peripheral tissue perfusion is big. Again, you have to have good assessment of that and intervene right away. They're going to have a lot of pain. There's a lot of pain with these surgeries, and they'll be on pain medication, impaired physical mobility, and risk for infection. And again, the major goals, you want to promote adequate tissue perfusion, relief of pain, improve mobility, and absence of infections. So neurovascular assessment, again, is vital. I think you're kind of seeing this as a theme throughout the musculoskeletal session. So every 1 to 2 hours for the first 24 hours, and let the patient know any signs and symptoms to assess and report right away. And then to relieve pain, the foot needs to be elevated, usually at the level of the heart. Use intermittent ice, pain medications, oral analgesics, and maybe non-steroidal anti-inflammatories. And improving mobility, maybe the use of crutches or a walker. If that is ordered, usually then a referral to physical therapy for training and fitting is done. And we just want to make sure that the patients are safe and don't have injury and protect them from injury. We want to prevent infection. If they do have any pinning done, any external devices, we want to teach them an aseptic technique for pin care. You'll learn more about that in the next PowerPoint. Wound care, keeping the dressing clean and dry, and reporting signs of infection. So is the following statement true or false? A bunion that fails to respond to conservative treatment often requires surgical correction. And that's true. Okay, now we're going to talk about osteoporosis. And this is characterized by a reduction in bone density, change in bone structure. The normal homeostatic bone turnover, which we talked about previously, is altered, and the rate of bone resorption is greater than the rate of bone formation, and it results in a reduced total bone mass. Risk factors for this are age, genetic factors, Caucasians tend to be at higher risk, hormonal factors, postmenopausal women, nutritional factors, and lifestyle factors. So assessment reveals skeletal changes and decreased bone density, and the bone becomes very porous, brittle, fragile. It can break easily, it can break under stress. You can develop compression fractures. Frequently results in compression fractures of the spine, fractures of the neck, the intercanteric region of the femur, and the Colles fractures of the wrist. So those are kind of common locations of fractures for people with osteoporosis. So what are the risk factors? Well, being female, especially postmenopausal, Caucasian or Asian, small frame. You see the picture of the woman there with a very small frame. She would be at higher risk. Postmenopausal, advanced age. Those who have low calcium and vitamin D intake are at greater risk. And those who have high phosphate intake, such as from carbonated beverages, because again, the calcium phosphate, if we have high levels of phosphate, that then tends to lead to our calcium being lower. So that can increase risk. Physical exercise, those who are sedentary, who don't do weight-bearing exercises, low weight and body mass index, all of those things are risk factors as well. Caffeine, alcohol, smoking, lack of exposure to sunlight are lifestyle risk factors. And as mentioned before, people who are on long-term steroids are at increased risk for osteoporosis. Those who are taking thyroid hormone or who have hyperthyroidism are at increased risk. Those heparin increases the risk, seizure medications. And if people have any malabsorption issues in their GI tract, they can't absorb the vitamin D or the calcium. Renal disease and hyperthyroidism are some of the comorbidity at risk. So osteoporosis does tend to be progressive. So here we have a picture with the normal bone matrix. You see how it's very dense, very consistent, and then osteoporosis, you see how it's very vacuous. There's a lot of, it's not as dense, and so it's more fragile and friable and increased risk for breaking. In fact, many times when people, especially older women, they come in with a hip fracture and they had fallen, you think that maybe they fell and then that fractured their hip, but many times their hip fractures and that leads to the fall. So here's the typical loss of height associated with osteoporosis with aging. So here we have at the beginning, we have a woman who's 10 years postmenopause and she's at 5 feet 6 inches tall, pretty much her premenopausal height. But 15 years postmenopause, the height loss can be lost 1.5 inches. In 25 years at postmenopause, the height loss can be up to 3.5 inches. And then you see how the spine changes too, and there's more curvature. So the patient with osteoporosis, it necessitates sufficient amount of calcium, vitamin D, sunshine, and weight-bearing exercise. And then there's some pharmacologic interventions to help as well. The selective estrogen receptor modulators, or SERMs, biphosphonates, calcitonin. We'll talk about those in a bit. And then the nursing priorities include improving bowel function, because a lot of these medications can lead to constipation, preventing injury, and managing. Okay, so we want to prevent osteoporosis in the first place. So having a balanced diet, high in calcium and vitamin D throughout life is very helpful. The use of calcium supplements to ensure adequate calcium intake. And it needs to be taken in divided doses with vitamin D because the body can only absorb 500 to 600 milligrams at a time. So if you have a woman who needs 1,500 milligrams a day of calcium, she actually needs to be taking 500 milligrams 3 times a day if it's all through supplemental. Or if it's a lot of it's in the diet, then at least twice a day with a diet high in calcium. Regular weight-bearing exercise such as walking or dancing. Water aerobics would not qualify as a weight-bearing exercise because when you're in the water, it's non-weight-bearing. So weight-bearing would be something like walking or dancing or lifting weights. Weight training stimulates bone mineral density, so weight training can be helpful as well. So here's a little bit about the pharmacologic therapy. And the biphosphonates, these inhibit osteoclast activity. And patients have to be sure to have sufficient amounts of calcium and vitamin D is needed as well in order for this to work. And all of these drugs end in the dronate. So there's alendronate, that's Fosamax. Risendronate is Actonel, and ibandronate is Boniva. And these drugs can help, like I said, they inhibit osteoclast activities, so they can help strengthen bones, but they do have some side effects. Primarily GI. They can lead to dyspepsia, nausea, flatulence, diarrhea, constipation. They can end up with GERD and even have ulcerated esophagus as a result. And we have a picture here for you of an ulcer on the esophagus that as a result of biphosphonates. So important teaching point with patients who are on these drugs is it needs to be administered in the morning, first thing in the morning on an empty stomach. It has to be taken with a full glass of water, at least 6 to 8 ounces of water. And then the patient must sit upright for at least 30 minutes, 30 to 60 minutes after administration. Calcitonin is another medication that can be given. This inhibits osteoclasts as well. It can be given by nasal spray or an injection. It can lead to nasal irritation. Patients complain of flushing, GI disturbance, and it's not prescribed if patients have seafood allergies. There's also selective estrogen modulators or SERMs, raloxifene or Vista. This can preserve the bone mineral density without estrogenic effects on the uterus, so it can be helpful. It is contraindicated in patients with a history of blood clots. Teriparatide or Forteo, this is a sub-Q injection that's given daily, and it stimulates osteoblasts to build bone matrix and facilitates calcium absorption. So that's another possibility. And again, with all of these drugs, adequate amounts of calcium and vitamin D are a necessity. Okay, question. How long does a patient taking bisphosphonates need to stay upright after administration? 10 minutes, 20 minutes, 30 minutes, 120 minutes? It's 30 minutes, 30 to 60 minutes. Okay, here's another question. A 77-year-old woman with a recent diagnosis of osteoporosis has had calcitonin added to her medication regimen. The nurse should anticipate administering the drug by nebulizer, B, intramuscular injection, C, intravenous infusion, or D, nasal spray. The answer is D, nasal spray. It can be administered by subcutaneous or intramuscular injection, but it's most commonly administered by nasal spray. So caring for the patient with osteoporosis, nursing assessment, again, looking at the occurrence of osteopenia, osteoporosis, what are the family history and risk factors. Do they have any previous fractures or histories of fractures? Doing a dietary analysis and seeing the amount of calcium, rich foods that they're taking in daily. What kind of exercise patterns are they having? Are they doing weight-bearing exercise? When did menopause occur? What was the onset of their menopause? And are they taking any medications such as corticosteroids or alcohol or smoking and caffeine? That can also be risk factors for osteoporosis. And again, these are some of the diagnoses like I talked about earlier. Knowledge will be an important one, deficient knowledge. Acute pain if they've had a fracture, risk for constipation, and then risk for injury. We want to hopefully prevent any occurs. And the major goals are to include knowledge about osteoporosis, its treatment, relieving any pain, improving bowel elimination, and preventing helping them understand the condition of osteoporosis and how to treat it and what the regimen is for them, relieving their pain through medication and whatever other means, non-pharmacologic, and improving bowel elimination and preventing. Okay, the next condition we're going to talk about is Paget's disease. It's also called osteitis deformans. It's a disorder of localized bone turnover. It's pretty rare. Only 2 to 3% of the population older than 50 years old has it, and it is more common in men and increases with aging. Pathophysiology is that there's excessive bone resorption by osteoclasts, and it's followed by increased osteoblastic activity, so the bone structure becomes very disorganized, weak, and highly vascular. And these patients are at risk for fractures, arthritis, and hearing loss because it can affect the bones in the ears. So if you look here at the picture on the far right, you see someone with the Paget's disease, and on the left you see the normal bone. So you can see how disorganized that bone is and how you could see that it could be at risk for fracture. So what you might see is skeletal deformities, mild to moderate aching pain, tenderness and warmth over bones, and the symptoms may be pretty subtle or insidious and may just be attributed to old age or arthritis. So most patients don't even have symptoms. So how is it treated? Well, nonsteroidal anti-inflammatories are given for pain. Calcitonin and bisphosphonates are used. And plicamycin or mithramycin, mithrasin, it's a cytotoxic antibiotic, may be used if it's very severe and it doesn't respond to any other therapy. Osteomyelitis, this is infection of the bone, and it can occur for a variety of reasons. It can be an extension of soft tissue infection, so they have an infection in soft tissue near a bone. It can extend right into it. It can be direct bone contamination from when there's an open fracture or traumatic injury, or if they've had bone surgery. And it could be bloodborne that's spread from another site of infection. This typically occurs in an area of bone that's been traumatized or has lower resistance. So it doesn't happen that often, but it can happen. And the most common organisms that cause this are Staphylococcus aureus, about 70 to 80% of the cases. But Proteus and Pseudomonas and E. coli also are culprits. So prevention is really the goal. You don't want it to happen. And early detection, if it does happen, and prompt treatment is important because it can reduce the potential for becoming a chronic infection or even disability. IV antibiotics are used to treat it, so it is an infection, it needs antibiotics, and it's treated up to 3 months. So they may be on 3 months of antibiotics. And then we need diet high in vitamins and protein to help with the healing. And then the affected extremity is usually immobilized to prevent a pathologic fracture because that area of the bone that's infected now has become weakened. And if it is chronic and it's not cleared with the antibiotics, surgery may be necessary in order to debride the necrotic material out of that bony area. So again, assessing the patient for risk factors, observing for their signs and symptoms of infection, which would be, they're going to have localized pain, they can have swelling, fever, drainage, elevated white count. With chronic osteomyelitis, fever may be low grade and occur in the afternoon or evening. Signs and symptoms of adverse reactions and complications of antibiotic therapy, and even superinfections may occur. So you have to really also assess their ability to adhere to the prescribed therapeutic regimen. If 3 months of antibiotic therapy, they need to maintain that for the whole time. So their diagnosis would be related to the pain, mobility, risk for extension of the infection because a bone abscess may form, and again, for the goals, we're going to want to relieve pain, improve mobility, eradicate the infection, and help them understand their. So they may need to be immobilized to help relieve the pain. Elevation is helpful. Handle these patients with great care and gentleness, and give pain medications. And physical mobility activity is restricted, so you want to make sure what is the activity order. Can they weight bear or partial weight bear or non-weight bearing? And then doing gentle range of motions to the joints above and below the affected part, and have them participate to the full extent that they can with activities of daily living, but it will be within some. Good nutrition to promote healing, lots of protein, vitamins, adequate hydration, administer and monitor antibiotic therapy through completion and make sure they're responding to it, and then teaching the patient and family about follow-up care and referring them to home health care if needed. So is the following statement true or false? The infectious process that characterizes osteomyelitis is frequently exacerbated by inadequate calcium and/or vitamin D intake. That's false. A variety of factors are implicated in causing osteomyelitis, however, insufficient vitamin D and calcium intake are not among. Okay, and then we're going to talk a little bit about bone tumors. There can be primary tumors of the bone. They can be benign or malignant. Benign tumors are more common and generally are slow growing, present very few symptoms or problems. But malignant, the prognosis depends on the type and whether the tumor has already spread. Osteogenic sarcoma is the most common and most often fatal primary malignant bone tumor. Metastatic bone tumors, they're more common than primary tumors. A lot of different types of cancers will metastasize to the bone. Breast cancer does, prostate cancer, and of course those are the most common cancers in men and women. Primary bone tumors may necessitate surgical excision, radiation, therapy, chemo, maybe even amputation. The treatment of metastatic bone cancer tends to be more palliative because once it's metastasized, it's considered stage 4, considered incurable, and then you just treat the symptoms. You treat it palliatively, you treat the pain, and they still may receive radiation therapy to get rid of the cancer in the bone, but it's palliative in nature, not curative. It's to help get rid of that in the bone and decrease the pain to that site. So nursing care is similar to that of other patients who've had skeletal surgery, and the priorities are pretty much the same. And again, you want to prevent complications. You want to promote healing, make sure that there's good nutrition. You want to prevent infection to the bone and extension to the bone. And somebody with a bone tumor, they are at risk for hypercalcemia because of all the breakdown of the bone, and it goes out into the bloodstream. So you want to monitor their lab works and then treat that if they do end up having hypercalcemia. So the patient with a bone tumor, again, doing a good preoperative assessment if they're going to have orthopedic surgery, monitoring their pain and treating that, observing for any signs and symptoms of complications post-operatively, monitoring their lab values, their electrolytes, their white count for signs of infection, and then again, really monitoring for hypercalcemia if needed. So we've talked about the diagnoses. I don't think there's anything different with this patient, a new one here. And the goals pretty much are the same as well. So good patient teaching about their diagnosis, the process of the disease and its treatment, and then prevention of pathologic fractures. When there is bony involvement with cancer, those bones become very, very brittle, and they can just break very, very easily. I had a patient who just moved her arm to reposition herself in bed, and she ended up getting a fracture in her bone. So we need to support affected extremities at all time and handle very gently. I like to put a sign on them, fragile, handle with care. And external supports, fixation devices, or even splints may need to be applied in order to help prevent a break in areas of known metastasis or bony lesions. And for them, weight bearing needs to be restricted and activity as prescribed, and assisted devices may need to be used as well. So the nursing care is similar to that of other patients who've had skeletal surgery. Priorities include patient education and prevention of pathologic fractures. As I mentioned, they may need to be splinted, supported, handled with care, and then preventing any potential complications. We don't want them to have delayed healing or osteomyelitis. We want them to have good nutrition to promote healing, and then looking at those lab works for possibility of hypercalcemia and treating that. So that's it for this PowerPoint, and thank you very much.